Apical impulse. Apical impulse is the lowermost and outermost point of definite cardiac impulse that is seen or felt. Normal apical impulse is produced by the left ventricle and the left ventricular portion of the interventricular septum. How to check for apical impulse. Position of the patient. The normal apical impulse is seen when the patient lies supine or with the upper part of the body inclined at 30 degrees. If not localized in supine position, the patient can be made to sit and stoop forward or laterally rotated to the left. Ideally, the patient should not be turned to the left lateral side for locating the apex, as cardia moves to a variable extent of 0.5 centimeter to 1 centimeter on turning to the left. Palpation of the apical impulse. To locate the apical impulse, place your right hand against the left side of the patient's chest wall. Using the tip of your finger, assess the apex beat. Use fingertips for palpating sounds and proximal aspect of your palm to check for heaves or lifts. Normal apical impulse. Normal site of the apical impulse is about 1 centimeter medial to midclavicular line or 10 centimeters lateral to midsternal line at the left fifth intercostal space in adults. Normal displacement is 1 centimeter laterally in the left lateral decubitus position. Normal apical impulse is confined to 1 intercostal space and has an area of 2.5 square centimeters. Normal duration of thrust of apical impulse is less than 1/3 of systole. Shifting of the cardiac apex may occur in the following conditions. Cardiac causes. Cardiomegaly. Non-cardiac causes include pleural or pulmonary disease, scoliosis, pectus excavatum, and conditions with elevated diaphragm, like pregnancy and massive ascites. Conditions where cardiac apex may not be detectable. Obesity. Pleural or pericardial effusion. Dextrocardia. Emphysema. Women, if the left breast obscures an impulse, it should be lifted out of the way. Position and character of apical impulse. Tapping apex. Felt as a hard rock or knock on the other side of the door. Seen in mitral stenosis. It is the palpable first heart sound. Hyperdynamic, forceful apex. Apex is shifted outwards and downwards. With less sustained lift, more than 1/3 of systole, but not throughout systole. Signifies left ventricular enlargement and volume overload. Apex is diffuse, and may be more than 3 centimeters in diameter in the case of aortic and mitral regurgitation. Heaving apex. Sustained outward lift of the apex, with duration of more than 2/3 of systole. Position of the apex may not shift if it is concentric hypertrophy. Heaving apex suggests pressure overload of the left ventricle due to aortic stenosis and systemic hypertension. A diffuse apex beat is seen in left ventricular aneurysm and dysfunction. Double apical impulse is noted in hypertrophic obstructive cardiomyopathy, left ventricular aneurysm, aortic stenosis with regurgitation, and left bundle branch block. Triple or quadruple apical impulse is noted in hypertrophic obstructive cardiomyopathy. Retractile apical impulse is associated with constrictive pericarditis and severe tricuspid regurgitation. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.